Welcome to the ASRS Oral History of Retina series. The purpose of these interviews is to capture first-hand stories from individuals with unique retinal insights of historical significance.
Through these discussions, we will fill in gaps in our understanding of the evolution of the science and practice of retina. And it's our hope that these discussions will serve as the illuminating element in the larger mosaic of the history of retina.
In the world of retina, there are few stories as unique as that of the Berrocals, a multi-generational retina tour de force with a legacy that goes back to the early days of our field. It is my honor to be joined today by Dr. María Berrocal, Director of Berrocal and Associates in San Juan, Puerto Rico, who will share a fascinating window into the history of retina through her unique upbringing and how that has impacted and inspired her remarkable professional journey. She is the eldest daughter of the late Jose Berrocal, an internationally renowned retina pioneer who was the first retina specialist in Puerto Rico and the Caribbean, and was the first retina fellow at the Bascom-Palmer Eye Institute with Dr. Edward Norton. Maria and her sister Audina, a world-renowned retina surgeon in her own right, grew up assisting in their father's clinic, where they mingled with a who's who of retina giants and witnessed the evolution of retina from scleral buckles to the development of laser photocoagulation, fluorescein angiography, OCT, vitrectomy, and the merge to microincisional surgery. Dr. Berrocal received her medical degree from the University of Illinois and completed her ophthalmology training at the University of Puerto Rico. She completed her medical and surgical retinal fellowships at the New York Hospital Cornell University with a medical retina fellowship with Dr. Gass at the Bascom-Palmer Eye Institute, where she received the prestigious Heed Fellow Award. She is a stellar surgeon who has focused extensively on innovating new techniques and approaches to complex ocular disease. She has participated in numerous studies of innovative treatments for the management of diabetic complications in retina surgery and is a principal investigator in the International Research Forum, PCORIS. Dr. Berrocal is a highly respected educator who has lectured extensively and performed live surgery in more than 25 countries. It's my true pleasure today to welcome Dr. María Berrocal. Welcome, Dr. Berrocal.
Thank you so much, Tim, for having me.
Maria, you and I have had overlapping careers for a long time, but your story has been incredibly remarkable. It starts actually before you're even born. Mm-hmm. So could you start a little bit about how your journey begins in retina?
Yes. My father was the first retina specialist in Puerto Rico and the Caribbean in itself. He was the first fellow of Dr. Ed Norton way back in 1963. Then he was a fellow in Boston with Dr. Escapins, and his fellowship was more towards diabetic retinopathy, which is one of my interests. And then he moved back to Puerto Rico as head of the retina department in the Department of Ophthalmology. And he would travel to teach surgery. He did the first retinal detachment surgery in the Dominican Republic at the time. And throughout his life, he kept very close connections with everybody in retina. So Dr. Gass would stay at home. Dr. Jerry Shields would stay at home. Stanley Chang. I had Dr. Norton's would be a frequent visitor. So I really grew up around all these people in retina as a child.
So, Dr. Berrocal, tell us when you entered the story.
Okay, well, it started very early. My family did not really believe in child labor laws, so I worked as a tech many summers in my father's office. At the time, he hospitalized patients, so I would go with him to round when I was very little on Sundays, and I always liked, the interaction of talking to the patients and the like. And my dad bought, this mask, and he would get dog eyes from the pound, and we would put them in the mask with a speculum, and we would practice doing removing cataracts and doing different things, cutting up the eyeballs, which was always a great thing to show to your friends when they would come home.
With the eyeballs in the refrigerator, of course.
Exactly.
That's correct. So you kind of grow up in Retina. You know the Shields and the Nortons and Gas. And so did you feel like that was inevitable, that you would go to medical school and become a physician and go into Retina?
Well, actually, I wasn't. I was a little bit of a rebel. I was the most rebellious one in my family, as from the perspective of my mother. I was a chess player growing up. I painted. I loved to cook. And my brother was, I was in Model UN, and I loved debate. So I studied politics and philosophy. Those were my majors. And I thought about what to do, but I really did not like law. I thought reading all those horrible cases all day long, was really boring. And I really liked helping people. So, and being in one-to-one relationships with people, I thought about, joining the Peace Corps, except that they build houses and I'm totally inept in that I don't have those talents. So I thought about going to medical school. So I went to medical school in Illinois, in the Midwest. I had never been so cold in my life. It was terribly frigid. At the time, although there were a number of women in my class, we were still treated as second-class citizens. And this was, I went to med school in 1982 to 1986. But I always resisted going into ophthalmology because I didn't want to do it by default. But I did the rotation with this wonderful ophthalmologist, general ophthalmologist there, and I loved it. And he was the nicest man. It really has to do with how nice the person you do rotations with and what you end up doing. So I applied to ophthalmology, and the rest is history.
Take me from medical school into your residency, and then from your residency to your fellowship.
My last year in medical school, I spent 2 months at Bert Glazer's lab at Johns Hopkins. And it was wonderful because at the time we were working trying to come up with anti-VEGF, with VEGF. And it was a very exciting time. Everybody in the lab was, it was a very vibrant place, I have to say. And that really sort of cemented the fact that I really wanted to go into ophthalmology. I did other rotations, dermatology, something I liked, but then I didn't like the patients. They were so focused on these minor imperfections that I thought it would be much more rewarding for me to go into ophthalmology. So I did my residency in Puerto Rico in ophthalmology, which was great because at the time, all of the patients without insurance went to the medical center. So I did around 500 cataracts by the time that I finished. But I still loved retina. It was what I liked the most. I thought nothing compares to being able to see pathology directly, where you actually can't do it anywhere else in the body to see vessels. I applied to a retina fellowship, and I was really, really fortunate because this was 1992. I was a fellow at Cornell with Dr. Coleman, Dr. Stanley Chang, and Dr. Harvey Linkoff. And it was fabulous to be at the right place at the right time. Dr. Iannuzzi, we would spend some time with him, and he had come up with ICG, was starting, and Stanley was developing. They had just developed some of the perfluorocarbon gases. We used them all, off-label with special consents, and the perfluorocarbon liquids. So I was at this transition point, which was just priceless. We were in the OR twice a week, from 7 in the morning until 2 or 4 in the morning. Stanley had the ability to fall asleep instantly between cases while I closed, so it was always would be who wakes him up, for the next case. But they were just wonderful, wonderful, wonderful times. And I just loved surgery.
And then you and I also have overlapped a little bit because you had some time at Bascom Palmer, which is interesting because that's where your dad started. And so tell us a little bit about that.
Yes, I was very fortunate because I was the Gass Fellow with Dr. Donald Gass, who is just a wonderful, brilliant human being. He was a great human being and a wonderful, wonderful clinician. You know, he had this power of recall and to describe pathologies. He kept his slides and would go back to look at them whenever he saw something that could be similar. That's how he described, so many diseases. But our history, he has a daughter my same age. So when I was 10, I spent a few weeks in his house in Key Biscayne. We used to ride bikes all the way to Miami in the bridge, and then she came and spent some time at home. So I was close to a lot of the children in ophthalmology, like Dr. Norton's kids, Dr. Wetzig's kids who spent some time at home. But being with Dr. Gass was really fascinating because you really realize how you need to, the power of observation is just so important in what we do. And I have tried to carry that out when I'm thinking about pathologies, particularly, when I do a lot of diabetic cases. They're all different. That is the beauty of diabetic pathology.
I'm always amazed with Dr. Gass of his ability to see things that no one else could see. And then when we had OCT available to us, suddenly we're appreciating what Dr. Gass saw.
But Dr. Gass told me a really important lesson besides that, and he did it all with a ruby lens, by the way. But they were doing the macular hole trials, which was observation or surgery at the time. This is 1993. And a patient came in, she had a macular hole in one eye, she was in her 50s, she was randomized to observation, and at that time, Kellyanne Wendell had just started doing surgery, and Bill Smitty was started doing them in Bascom Palmer. And Dr. Gass pulled the patient out of the study. He said, listen, we know what the natural history of this is. You're not going to be able to drive or do anything. You're going to end up 2,400. So I think you should get surgery. And everybody was very upset at him, everybody from the study. But he did what was right for the patient. And that is a lesson that I have carried on, that I always talk about. You have to think about the patient, their circumstances. It's different if you have insurance, if you don't have insurance, if you can come for follow-up, if you can't, all of these things matter when we're treating. We're not treating eyes, we're treating patients.
So Dr. Berrocal, you have this incredible training experience in retina and an opportunity really to go anywhere in the world. Tell me where you go and why.
My dad had some health issues, and we are a very close family, and I adored my dad, and I really wanted to be with him. So that is why I chose to go back to Puerto Rico. I also felt that I could help more there. At the time, a lot of the bad diabetics were sent to Stanley from Puerto Rico, so my contributions, I felt, would be more significant there. I could help my people more. And it was wonderful working with my dad in his office. And my dad was a feminist. He told me, you're smart, you have to get a career. I don't want you to ever depend on a man for anything. If you marry the wrong guy, kick him in the butt, and that really resonated in me forever. And he basically let me do whatever I wanted. He was always trying to be in the latest advances. So he truly enjoyed, being in the operating room with me. We used to operate on Saturdays, and we would have he would have an OR, I would have the other one. I learned a lot about scleral buckles. I learned a lot about pathologies. Whenever I didn't know what something was, he knew. So it was really priceless. I never believed in what people say that about work-life balance, because work is your life, is part of your life. It's not like you start living the moment you leave the office. So, with my dad, he would do his slides at home, we would help them, and that's what I do. At home, the kids would be doing homework, my husband was reading journals, I was working on slides or whatever, and we were all together at this. So I always took my job home. because I'd rather be home with them working in my computer than being in the office without them. I think it's nice to involve your children in your work because your work is part of your life.
What do you think are some of the most incredible advances that have impacted your patients and how you care for them?
I think wide-angle viewing systems, the gases, long-acting gases, heavy liquids, VEGF, anti-VEGFs, and small gauge vitrectomies, and now heads-up surgery. I'm an older surgeon. I've been doing surgery for over 30 years, and my neck would kill me at the end of the day. And since I do heads-up, it will lengthen the time that I will be a productive surgeon most likely. And all those things, better visualization are key. But I would say those are the main advantages. And we have a lot of our colleagues to thank for all of those advances. Stanley Chang, Jean De Juan, Harvey Linkoff, just to name a few.
What I love too is that you're able to take things from the past and put them into perspective today. Very few people are buckling now, most using vitrectomy approaches, but you still incorporate buckles even in eyes that are relatively complex.
To me, this was one of these illuminating moments. I have this patient who I did the primary vitrectomy for a detachment, had some, breaks that extended posteriorly. And he did really well. And a year later, he came in with a detachment in the other eye. And I said, listen, it's not as extensive. I'm going to try a different type of surgery. I'm going to put, just open that quadrant and put a piece of sponge, which I was lucky enough to learn from Harvey Linkoff. Most people are not that proficient with sponges, which are actually fabulous for buckles. If I have a detachment, I hope somebody can put a little piece of sponge. And I did that. And the next day he goes, this is so much better than that horrible vitrectomy surgery that you did for me, where I couldn't see anything until the gas went away. I couldn't work. These are all the things about our patients that we don't think about. The impact on their lives by what we do. I started doing more buckles because during the hurricane in Puerto Rico, where we were without electricity, patients had trouble coming in. I had this man who lived alone, comes in with a detachment, had to go up 15 floors every day. There's no way that man could have positioned, with a gas bubble. So I did a buckle and he was able to continue, getting water and doing all the things he had to do. So sometimes, when we think that something is simpler, maybe it's simpler for us, but it may not be, better for the patient.
You have a practice where you end up operating on patients who have really only one functional eye and something catastrophic has happened to that eye. What's that like as a surgeon?
Well, it instills a little bit of fear, which we should all have, because, you have such a responsibility. You can blind, this person. And, and deciding when to operate on someone, you can be more aggressive on somebody that has two eyes. So you have to adapt sometimes your techniques. That is actually how I came up with this limited membranectomy. I had this patient who had this massive fibrovascular proliferation, diabetic, heavy smoker. And I did his first eye that had a detachment, and I couldn't fix it. I operated him 3 times, and he ended up NLP. The second eye had these membranes, but the fovea was attached under this thick gliotic sheet that was attached to the arcades. And the patient, every time I saw him, the vision started dropping from 20/60 to 20/70, 20/80, mostly because of the thickening of the hyaloidal plaque. And he kept begging me to do surgery, and I didn't want to touch that eye because I knew what happened to the other eye. I knew it was practically impossible to peel all that. And then I thought about it, and I said, listen, the whole posterior pole is attached, so let me try something. So I actually went in and I opened that hyaluronic. I did relaxing incisions, and that eye remained stable for years until he died. And I have used that. That's how I devised that technique, which if I hadn't had this person, I would have tried to maybe remove everything, but it's not necessary in all cases. So it makes you think outside of the box to have those challenges.
I also know that you're an incredible chess player. And I think of you when I think of that because you're very strategic in your thought processes going forward. And I think of that as how you play chess. So can you tell me a little bit about the chess story, when it started for you and how that kind of tied to ophthalmology?
I think teaching chess to a kid is one of the greatest gifts you can give them. My dad was a chess player, a very good chess player, and he taught chess to my brother and me when we were little. My brother is 3 years older than me, and I'm 7 years older than Nina, so it was mostly my brother and me. And at the time, before Czechoslovakia became communist, Ludek Pachman, who was a grandmaster, went to Puerto Rico, and he would come home and teach us chess. And he would make me, I was probably 7 or 8 at the time, he would make me play chess without a board, by memory, sort of like as you see in The Queen's Gambit. She sees the board in the ceiling, the same type of thing. And he would make me, take it to maybe 15, 16 moves. It's very hard to do, actually, because you have to picture the table on you. But then I started playing competitively. He went back to Czechoslovakia, and he was imprisoned, actually, by the communists for a while. And but after that, I played competitive chess. This was the time of Bobby Fischer was around, so chess was cool. It was not just nerdy kids; it was people with long hair. And I used to go every Christmas to New York, and we would play at the McAlpin Hotel, the high school championships. And I usually won the female part because there were not that many female champions. But something that nobody knows about me, which I think is probably relevant, is that I was actually a centerfold. In the Daily News in New York, my picture was in the centerfold playing chess. So yes, I was a centerfold once.
To me, the chess story is a little microcosm of your story. I think you strategically think ahead, but at the same time, I think that you're very relaxed about how you do things and the persona that you put out to everyone. Do you think that's important?
Well, I think that's cultural. That's very Puerto Rican. It's like I never really realized how much of a perfectionist I was until one of my closest friends from college, he goes, "You're a super perfectionist. It's just that you mask it with that aura of relaxed island vibe." And I thought about it and I said, wow, that's probably correct. I try, I'm very hardworking. My life really is ophthalmology. I come home and I'm always doing ophthalmology related things. I try to enjoy it as much as I can. And I figured I'm going to do it till I stop enjoying it. My kids joke whenever my husband talks about retiring, my kids start laughing because mother's never going to retire. She's going to die in the office. Who knows? But the beauty of Retina and what we do is the many different layers that it has. It's like we can see patients, we can do medical retina, we can do surgical retina. We can, you see a lot of surgeons that when they get older, they just do medical retina only. We can lecture, we can teach, we can travel, we can write papers, we can work with industry. There's so many options that we have, and I think that's what makes it so vibrant and exciting. And I think the ASRS has really been instrumental in that. You see, I remember when the first meeting happened, that it was in the Virgin Islands on a boat. I thought that was so cool. Unfortunately, we were too large to be on a sailboat anymore, but I thought that having a society that was inclusive, that was at the forefront of everything, because it was started by these, Retina cowboys, right? Who wanted to do something different. We had the Retina Society, which was more traditional, Boston, Scapins. Then we had the Macular Society, which was more medical. And here, was this society of, breaking all boundaries. And now is the most powerful society that we have. And with numbers comes power, political power, and the ability for us to make changes in government, changes in policy, changes for our patients, and that is remarkable.
And I think ASRS also has benefited by its diversity, and you've mentioned the inclusiveness, but really it's the society, I think, that I've seen more women move forward faster. And I think that represents sort of that inclusion that the society focuses on.
Yes, I think ASRS is very international. Even though it's American society, you go to every meeting, and it is sort of like the meeting that international retina specialists go to. It allows for participation of everyone, and I think that is its true strength.
I agree with you how remarkable it is to have a society that has grown so rapidly, been so inclusive. You think about it in some of the major advances that we've talked about here and talked about at the ASRS, they're a little slower to get to some of the other societies. And I think that's one of the unique advantages of this society for our members. So if you were to leave young women coming into medicine in particular, a piece of advice that you think would be helpful, what would that be?
Don't be afraid. Don't be afraid to push the envelope, because we are not there yet as women.
Thanks for joining us today.
Thank you.